Hello everyone, this is a case of high-grade serous endometrial cancer. Apparently the patient is in stage 3C2. In the imaging, multiple pelvic and para-aortic nodes were enlarged. So we are proceeding with the debulking surgery in this case. So firstly, we are proceeding with the hysterectomy, opening up of the retroperitoneum, identifying the ureter. Then we are proceeding with the infundibulopelvic ligament of the right side. As because on the imaging the cervix was not involved, so we are not proceeding with the radical hysterectomy. So the hysterectomy in endometrial cancer is basically a type A hysterectomy as per the Querle-Moore classification. So with the help of the ligature, I am opening up the spaces. After identifying the ureter, I am moving away from the ureter so that we will not injure the ureter. Now I am on the bladder flap. She is a case of post-cesarean section. History of previous 2 cesarean sections, so bladder was a bit adherent in this case. I'm trying to create a plane. Now on the left side, some sigmoid adhesion. So we have to open the sigmoid adhesion to enter the retroperitoneum to get a clear view of the retroperitoneal structures and retroperitoneal anatomy. So counter traction and traction helps very much to identifying the proper plane. Some flimsy adhesions that are also released. Last part of the bowel that is adherent with the left-sided IP ligament. I'm trying to release that so that we can skeletonize the IP ligament and also enter the retroperitoneum. Now opening up of the retroperitoneum. Now I am coagulating the round ligament of the left side. Here you can identify just below my left hand grasper there is a huge pelvic node, most likely the extranelia group. So now we are trying to identify ureter, our friend. That's our extrailiac artery. Yes, so just beside the extrailiac artery that lies our ureter. I'm trying to delineate the ureter in a proper way. So once we have identified our ureter, I am taking the left-sided infundibulopelvic ligament. So once that is done, we are moving anteriorly in the bladder flap. So in this case, there is a small fibroid in the lower segment, low anterior fibroid, and bladder was adherent. So we have to move gently so that we will not injure the bladder. That's the posterior leaf of the broad ligament. So in this case we don't need full ureteric dissection, as because the cervix is not involved. So type A hysterectomy is sufficient. But the scan shows that there was deposit on the left side pelvic peritoneum. So I will take that peritoneum along with my specimen. That's my ureter, just below my grasper. So you have to be away from that. So just above my ligature is the uterine artery, you can clearly identify. So with a bit by bit dissection, I'm trying to skeletonize the bladder from the uterus, which is very much adherent here due to previous cesarean section. So now I'm trying to create a lateral window if possible. Sometimes when bladder is adherent anteriorly, we try to create a lateral window. That's because in the lateral window technique, bladder is not adherent in the lateral side, mostly adherent anteriorly. So that's the uterine pedicle of left side. Partially taken the uterine pedicle, just coagulated, and after that again trying to skeletonize the bladder. Now we have got a good plane. So traction and counter traction is very much important in laparoscopy. Yes, that's a very good plane. So till now we have not used any manipulator in this case. That's our uterine pedicle, duly coagulated. So now, as because we have to take the posterior part of the pelvic peritoneum, I am identifying the ureter again. So only the peritoneum has to be taken, so you have to keep track on ureter and also on the rectum. So the whole of this butterfly peritoneum is been included in the specimen. Now going posteriorly into the rectovaginal septum. So that's an avascular space, so if we go correctly there will be hardly any bleeding there. Coming back to the uterine on the right side, that's the uterine pedicle, duly coagulated. So finally uterine is taken, and also some part of the Macken rod on the left side also. So now for the opening of the vault, we are using a sponge stick from down below through the vagina. So that's our sponge stick is coming up. With the help of the monopolar, I am opening up of the vault. The anterior part of the vault is gone. Now on the posterior part, the last part of the vault remains. Yes. So that's the end of the hysterectomy in this case. So once the specimen is delivered vaginally, we are moving with the pelvic lymphadenectomy on the right hand side first. So firstly, we are on the psoas major and taking all the lymphatics lateral to the extrailiac vessel, towards the extrailiac vessel. So I'm trying to skeletonize the extrailiac artery here. That's our deep circumflex iliac vein. That's the limit of pelvic lymph node dissection. After that, we are separating vessels from the psoas major muscle. Superiorly, you can identify there is a node above the deep circumflex iliac vein, so that is being incorporated in the specimen. So there are two techniques of pelvic node dissection. One is medial approach and one is lateral approach. So if you go with the lateral approach, that is dissection in between the psoas major and the vessel, then all the lymphatic tissue will be taken up in the specimen. So after that, we are proceeding medial to the extrailiac vein. That's our pubic bone. So here we have to be very cautious, as because corona mortis will be there. Corona mortis is a connection of the extrailiac system and the intrailiac system. It is an accessory obturator vein that is coming out from the extrailiac vein, medial side. So that's a obturator internus muscle. So this vein coming up is the obturator vein, and we can see there is a communication between this obturator vein and the extrailiac vein. That's our corona mortis. So in this case, the obturator nerve lies below the vein, but there is a lot of anatomical variation. It can also be below the vein also, the vein below the nerve also. So the lower limit of the pelvic node dissection is the obturator nerve, and the medial limit is the intrailiac artery that we can clearly identify here. So now we are at the junction of the intrailiac and the extrailiac artery. So that's the last part. So right side pelvic lymphadenectomy is complete. So after a wash, it was fine that there is no bleeding. So moving forward, on the left hand side, the same step repeats. Firstly, on the lateral of the extrailiac vessel on the psoas major muscle. Now in between the psoas and the vessel. So in the left hand side, you can clearly identify some large nodes are visible. So through this lateral approach, we reach up to the level of the pelvic floor initially. That's our extrailiac artery. So now I am trying to separate the lymphatics from the extrailiac artery, and that is the deep circumflex iliac vein below my ligacture. There is a big node on top of that. Now we are separating the nodal channels with the lymph node from both medial and the lateral. The medial boundary is the obliterated umbilical. So there are some stark node along with the extrailiac vessels on the left hand side. So that's the separation from the obliterated umbilical from the medial end. So now we are approaching towards the stuck node. It is mostly stuck on the vein, it seems so. So I am trying to skeletonize the nodal tissue from the vessels. With proper traction and counter traction very much helpful to get the right plane. But in this case we prepare for any inadvertent vascular injury and prepare the vascular set if needed at all. That's the vein. So the node is being separated from the extrailiac artery. Now we can clearly identify the node is densely attached with the extrailiac vein. So now I am trying if we can separate the node from the extrailiac vein, and luckily in this case the node got separated from the extrailiac vein. But sometimes if it is densely stuck, we may have to partially take some wall of the extrailiac vein and we have to then repair it. Part of vein is still attached with the node and I am trying to separate that. Now a plane is popping up. So that's a very crucial area. And the vascular clamps and the sutures has to be ready in these type of cases where we are anticipating that node is adherent with the vessels. But I got lucky in this case that the node got separated, so we don't need the vascular set in this case. So this large node is out. Now we are moving into the obturator fossa, separating the obturator group of node from the extrailiac vein. So that's the area of corona mortis. Yes, this is the corona mortis. You can identify the bone. So that's the lateral limit of pelvic node dissection. That's our obturator nerve. So we have separated all the lymphatic tissue from the obturator nerve. The last part remains, the intrailiac chain, and the left-sided pelvic lymphadenectomy is complete. So now moving upward in the left common iliac. Some enlarged left common iliac nodes are also there. So this left common iliac lymph node is being removed. So once that is done, we will be moving forward with our para-aortic dissection. So till now we are using 5 port, one supraumbilical camera port, and on both right and left side 2 assistant port. So that's our right sided ureter. I'm trying to separate the ureter from the vessel. Now we are working on top of the common iliac on the right side. That's our psoas major. So that's the right common iliac group of node. So below it will be our right common iliac vein, so you have to be very cautious here. Usually up to the level of the IMA, if we can dissect, we are dissecting with this kind of approach, and after that we will be making an suprapubic camera port, and all the lap stacks will be moved forward and then in the other direction. So that's our vein. So we are moving upwards towards the common iliac junction. So that's the vein, and then the psoas major is very much prominent. So that part of the paracaval lymph node is also removed. We're keeping it on the psoas for the time being. So in this case, in the imaging, patient has very enlarged left-sided para-aortic node. So we are proceeding of that area. So here we can identify some large node is coming up. That node is also stuck with the vessel. That's our left common iliac artery. So I'm trying to skeletonize the lymph node from the vessel. I'm trying to make a plane in between them, the psoas and the node, and also the node and the vessel. That's the vein is coming up below the artery. So now separating the node from the psoas major muscle. That's a large node. So in this part, the node is very much stuck with the vessel, you can clearly identify. So with the suction, I am pulling the ureter away. So he is lucky enough to get a plane between the vessel and the node. That's one large node from the left para-aortic group. After that, we have again moved towards the iliac bifurcation. So below my ligacture will be the left common iliac vein. I'm trying to skeletonize the left common iliac artery. So that's the aortic bifurcation. So from this side we will approach the left para-aortic node, the remaining nodes. You have to be very careful in this plane regarding the ureter. Ureter will be 1 to 2 centimeters below in this plane. So that's our ureter. So I'm trying to lateralize the ureter, and that's the big node. The part of the node was removed from below. Now we are pulling the node upward so that all of that chain will be cleared off. Now the camera position has been shifted. Now the camera on the suprapubic port. So that's our duodenum. So I'm pushing the duodenum up with a gauge piece. So you can identify on the right side there's the conoidal vessels, and below that lies our ureter. That's our IVC. So with the help of the gauge piece, I'm giving the traction on the bowel, and both on the left and the right hand side the peritoneum has been pulled off to create this plane. So now we are at the last part. We are close to the left renal vein, so I am pushing out the small bowel with the help of the gauge piece. So after the complete dissection, you can identify the left renal vein, the left side ureter, on this side the right side ureter. So in this case the IMA was originating from the common iliac. This is the pelvis node area of the right side, the left side, and that's the final picture of the pelvis after we close the vault. That's then the picture of the specimen. Thank you all for watching this video.